This is the Emergency Medical Minute, sponsored by Mile High Ambulance.
Hey EMM, it's Mason here to tell you about an exciting new opportunity we are offering. In an effort to tangibly improve our organization's commitment to equity, diversity, and inclusion, we created the Diversity and Inclusion Award that fourth-year medical students that identify as underrepresented in medicine and are applying to emergency medicine residencies are eligible to apply for starting today. We understand that the cost of applying to residency adds up, and we want to do what we can to ease that financial burden. We are extending 3 $200 awards to selected individuals following a blinded review of all applications. Applications will be accepted through the end of November, and winners will be announced mid-December. Check out our website at www.emergencymedicalminute.org/EDI-award for all the details and to access the free application, or click the link in our show notes. Thank you.
All right, well, good morning. This is based on a New England Journal of Medicine article from August 2021. It's titled Angiography After Out-of-Hospital Cardiac Arrest Without ST Segment Elevation. So, as we all know, out-of-hospital cardiac arrest continues to carry a very, very poor prognosis. Most meaningful survival rates are well under 10%. There's a number of ways in which you can quantify or qualify what meaningful neurologic outcome based on a modified score, a standardized score. And there is a lot of information about the value of taking a person to the cath lab in the context of out-of-hospital cardiac arrest. The thinking being the most common cause of why individuals arrest out of hospital for many demographics is coronary ischemia and a heart attack leading to dysrhythmia, leading to death. And so the kind of conventional thought would be the sooner you can get those people to the cath lab and intervene on a lesion in their coronary arteries, the faster they might do better. The data on that is extremely mixed. So does anyone have any thoughts about what people you've seen us take emergently to the cath lab if we get ROSC from an out-of-hospital cardiac arrest? The trick would be it's the same ones we normally would take to the cath lab emergently, which is a STEMI. So if we have a high clinical suspicion, which essentially is like a STEMI on pre-hospital 12 lead, which then devolves into dysrhythmia and then they arrest maybe en route, I mean, it's pretty clear what caused that arrest, right? This is not like a found down person who has a prolonged downtime, non-shockable rhythm. After you get ROSC, you can get a number of different dysrhythmias called reperfusion rhythms. They can look like STEMI, they can look like VTAC, they can look like all sorts of things. So this study looked at, do these patients benefit from taking them emergently to the cath lab? So if someone comes in with ROSC and do they benefit from us whisking them to the cath lab, maybe even before going to the ICU, to see if there's something that the interventional cardiologist can intervene on? And unfortunately, the answer is probably not. So they looked at, this is called the Tomahawk trial. It's one of there's a number of trials that have looked at this question, but they group patients into two groups, one early versus delayed angiography. So the early ones still had an average or median of 2.9 hours until they went to the cath lab. And you can imagine why. There's a lot of resuscitation that goes into ROSC, and then there's oftentimes your therapeutic normothermia or something like that. So it takes time. They're unstable versus ones that went to the cath lab over 24 hours afterwards. And they looked at the primary outcome was, did more people survive, 30-day more all-cause mortality? And there was no difference between the groups. And in fact, there may have been a little bit of a trend towards worse neurologic outcomes in the group that went to early angiography. So essentially, this is just one study. There's a number of studies that have looked at this. And I think what the takeaway really is if you have a really high suspicion, whether there's a STEMI or a really good clinical story, like the family saw them clutch their chest, they were complaining of chest pain, and then they went down and arrested, that's a conversation that we're going to have with the interventional cardiologist to take them emergently to the cath lab. But, the ones that just come in as a kind of undifferentiated arrest that we get ROSC in the department, there probably is not that much benefit of rushing them to the cath lab, and instead, therapeutic normothermia, kind of medical optimization, and taking them to the ICU for delayed angiography is probably just as helpful.
We'd like to thank our sponsor, Health One Continental Division, and Swedish Medical Center for their financial contributions to the EMM. Donations from them and listeners like you make it possible for us to fulfill our mission of producing and spreading free medical education to the masses. If you enjoy our show, please consider making a one-time or recurring donation to help cover our operational costs and keep the EMM awesome. Click on the link in our show notes to make a donation. Thank you for listening.